Yeah, well, I want to welcome our CyberSight community today. We have an exciting day of live surgery. One of our volunteer faculty, Dr. Kevin Barber, is joining us live from Florida. Kevin, welcome. Tell us a little bit about the day today and what cases you've prepared for us.
Hey, good morning, Hunter, and good morning, afternoon, or evening to all of you globally. It's great to be here today. As Hunter mentioned, my name is Kevin Barber. I'm an anterior segment surgeon on the East Coast of the United States in Florida. And welcome to my operating room. Very happy to share today with you two great teaching cases. The first case, we're going to highlight some pearls for a MIGS procedure combined with a standard phaco. And then our second case will be a toric intraocular lens case. Back in January, we did a CyberSight live stream, surgical live stream, just like today. And in that case, we did a femtosecond laser assisted digital marking intraoperative aberrometry to do a toric lens. And the feedback that we received was that you, the global audience, really wanted to know more how to implement torics without all of the expensive technology. So you were heard, and so that's what we're going to do today. Today's case will be a toric, not using the technology, but really emphasizing the fundamentals. And so I'm excited to kind of walk you through that process today of an entire patient experience with a toric lens. So two main learning objectives today. The first is to make you familiar with the basics of a MIGS Cahook dual blade goniotomy. Dr. Cherwek and I will share pearls on how to make this option a reality in your practice. And then our second learning objective is to become familiar with the entire process of a toric patient experience. So before scrubbing, I just wanted to give you a little context. So I'm going to be using an Ingenuity. That is a 3D heads-up display here. So you can see the large 3D television here. Our patient is ready to go. To my right, I sit at the 12 o'clock position. To my right will be Juvie. She is our excellent scrub tech and mind reader. And then over here we have John, our anesthesia provider, who will keep everybody healthy and happy. And so with that, over to you, Hunter. I'm going to go scrub and get started on this case.
Yeah, thank you, Kevin. And as always, I really appreciate you taking the time and making the team approach to cataract care. In this case, Kevin has selected a 63-year-old patient with bilateral cataracts, and the patient has mild to moderate glaucoma, open angle glaucoma. The patient is hyperopic, is plus 375 was the best corrected vision, and the vision before surgery was 20/50 in both eyes. When Kevin did the gonioscopy, there was a mildly narrow AC, which we would expect in a hyperope, but he was able to see the scleral spur 360. The cup to disc ratio in this patient was 0.6, and there was early nasal step findings on the visual fields. So when Kevin sat and spoke with the patient, and the patient was already going for cataract surgery, he discussed that there was the opportunity to also treat the mild to moderate glaucoma with a Cahook dual blade. So Kevin's going to be able to demonstrate that. As we've done before on CyberSight, it's really important to practice through simulation. So if you're about to start your first goniotomy or your first combined MIGS case, I strongly recommend that you get some animal eyes or the model eyes and practice this technique. It's not simply moving the Cahook dual blade around the anterior chamber. It's positioning the patient, looking at the gonio lens, and you can practice a lot of that before you ever begin your first MIGS case. So please notice that, and I would strongly recommend, and I'm sure Kevin will talk about, how positioning and using the angle, the visualization prism and the look at the angle are very important steps that you can practice on any cataract case before you go to your first real live patient.
I'm ready to go.
Fantastic.
So as you can see, we just made the paracentesis. Thank you for that, Dr. Cherwek. Okay, I'm going to give you just a little bit of numbing medication here. So I'm injecting a little bit of non-preserved lidocaine here. I do that on all my MIGS cases, just because we are going to be manipulating the anterior chamber a little more than with a standard phaco. This is my OVD. I'll disperse it. And then I'll be creating corneal incision. This is a 2.4 millimeter keratome.
And I liked how you stabilized the wound with the paracentesis.
Yeah, lots of different ways to do that, but I have become comfortable just using the viscoelastic cannula. That's just one less time I have to come in or out of the eye, one less instrument I have to use. So now we're performing the capsulorhexis. I'm going to aim between 5 and 6 millimeters here. Just controlled process here of walking the capsule around. Now we'll move on to hydrodissection. Thank you. This is a chain cannula. I like using the chain cannula for hydrodissection. It allows me to hydrodissect subincisionally. So a nice little fluid wave there. Chain cannula also allows me to kind of manipulate the nucleus and rotate it here. All right, we'll go right on into phacoemulsification. So I'm using an Alcon Centurion unit. My technique, I use several techniques, but kind of my go-to technique is a stop and chop. So I'll make a central groove. Once I've got adequate depth, I'll go ahead and crack. And then I do kind of a modified chop where instead of chopping from the anterior segment of the lens, I'll bring it up from the posterior. And that just allows me to manipulate that nucleus without causing a lot of stress to the zonules. And it also allows my phaco needle to just stay fairly stationary in the central safety zone. So I'm not getting myself into trouble.
Yeah, you've done a great job of keeping that phaco needle just at the iris plane and letting the second instrument do the work and rotate.
When I teach residents, I'm a big advocate of that. Let that second instrument do a lot of the manipulation of the nucleus and keep your phaco needle as central and as stationary as you possibly can. As we get to the end, I'll place that second instrument underneath my phaco needle just because there's less lens material there to protect the capsule. So I've now gone into my epinuclear setting. It's a lower phaco energy, a little bit lower vacuum. And I'm pretty happy with that. So we'll go ahead, switch over to
Cortex.
Irrigation aspiration to do the soft lens material removal. Thank you. Kind of use these C motions or partial circular motions to strip the cortex again to my central safety zone here. The little pieces of cortex there. All right, so as we normally would, I know there were some questions already about, do you do the MIGS procedure first or the phaco first?
Correct.
I prefer the phaco first. Yeah, I mean, you can do it either way, obviously, but I prefer the phaco first. Now, one thing I'm doing differently here is I'm gonna go ahead and inject more viscoelastic in the angle just to begin to open that angle up because that's gonna help with visualization here in just a moment. So this is a monofocal lens. It's a preloaded lens by Alcon, the AU-OOTO lens. That slides in very nicely. I'll use my second instrument here just to drop the trailing haptic into the capsular bag. Okay, so we've essentially finished the phaco portion. I'm now going to prepare for the MIGS. So the first thing I'm going to do is I'm going to rotate the patient's head. So I'm going to tilt your head to the left just a little bit, good, about 30 degrees. And now I'm going to rotate my operating microscope also about 30 degrees. And this helps get a good gonionoscopy view. So the first real pearl for MIGS procedures is you just have to get an excellent visualization to really do the procedure well. So the first thing I'm going to do is put a little extra viscoelastic in case I burp some out during the lens insertion. You do not want a soft anterior chamber because then you will cause a lot of corneal stria when you're doing your gonioscopy. Place some viscoelastic on the cornea. You can also put it on the bottom of the gonio lens. And then right away, we can see a pretty good view of the angle. So I like that. So I'm going to go ahead and insert the hook blade. And then I'm going to take just a moment to focus down to make sure I've got excellent visualization. I might mag up just a little bit here. I'm going to do what's called an outside in. So you can see this is our trabecular meshwork. I'm going to go ahead and engage the trabecular meshwork. And I'm going to go counterclockwise. And there's a real feel to this. If there's not any resistance, you're probably not fully engaged. If there's too much resistance, you might have the angle a little too steep. So now I've done about 2 clock hours there. I'm going to come back here and now go backhand clockwise. And I'm trying to connect my 2 goniotomies there. And what that does is if you connect them, you'll actually amputate these little strips here of the trabecular meshwork, which is actually what you're removing. So when I see that strip of trabecular meshwork, that tells me I've accomplished my goal. I now have a nice goniotomy performed here about 3 to 4 clock hours. Oftentimes you'll get some reflux of blood. In this case, we don't have that. And that is essentially a Cahook dual blade goniotomy. All right.
No, Kevin, that was fantastic.
So now, thank you. Again, the real key is visualization. And sometimes it's not easy to visualize it as it was in this case. We got a little lucky here. And so really that's the thing I need to emphasize the most is taking the time to get good visualization. Let's look at the Cahook blade. I did want to just show there's 3 different ways you can do the Cahook maneuver. I'm not going to talk about those in depth. There's videos about that, but what again I did is an outside in. So I started here, I went this way, and then I came back over here and started here and went this way, and I connected the 2 right in the middle. The advantage to that is that the strip of trabecular meshwork that you're excising or removing gets completely amputated here in the center so that there's not going to be a residual tag that's left in the eye. Okay, so now I'm injecting what's called Trimoxy. This is a compounded medication of moxifloxacin and triamcinolone. It's compounded by Infamous Pharmaceuticals. I've been doing this for quite a few years, and it's worked very well for prophylaxis of endophthalmitis and also for postoperative inflammation control. So I've really enjoyed that. So now we're just going to remove the viscoelastic. I'm going to go under the IOL. It is important to remove the viscoelastic from underneath the IOL because it's common to get postoperative pressure spikes when you do a MIGS case. So you want to make sure, you want to do an extra good job of removing all of the viscoelastic. So I'm going to go ahead and go now into my viscoelastic setting, which just has a higher vacuum. I also come all the way over into the angle if there's any blood or viscoelastic. I want to remove that. Again, trying to prevent postoperative pressure spikes. It's the one thing I really think about when I do a MIGS procedure. Okay, and finally, we're going to hydrate our incisions. These patients I'll put on a non-steroidal. We do sometimes see a little bit of extra inflammation, although not much compared to just a standard. Like I'm going to check the pressure, making sure I'm leaving the eye close to a physiologic pressure. And that concludes our first MIGS case. So Hunter, over to you, and I'll be back at the computer in just a minute.
Thank you, Kevin. And I think, the key that Kevin demonstrated was pre-op planning, making sure that he had the right patient for the right procedure, and then he executed that plan. Also, you saw during the procedure how smoothly he rotated the patient's head. That is something you want to prepare the patient for, so that the patient can cooperate, looking in the right direction, knowing that they may be expected to turn their head from one side to the other. I think the absolute crystal clear thing that Kevin demonstrated was how important your visualization is before you do a MIGS procedure. And that is, again, something I would strongly encourage anyone who's starting MIGS to start practicing either in the wet lab through simulation or on your regular phaco patients, putting the lens on the eye, getting comfortable, practicing to see how the angle opens up and how you can visualize that. You are using both hands, and a lot of people have a learning curve with how to hold that lens with their non-dominant hand. Kevin, as he said, demonstrated the hook dual blade. This is a very popular procedure that's done for mild to moderate glaucoma at the time of cataract surgery. One of the advantages of doing the phaco first is you open up more space, especially in a hyperope like what Kevin just demonstrated, so that you're not worried about dinging or hitting the lens, and also you have a better pathway across the eye. Kevin, I think you're ready for your talk. Is that correct?
Yeah, I'm here. Those are great points, Hunter. You're absolutely right. That is why I like to do the phaco first. It creates a lot more space. The only reason I wouldn't do it is if I'm worried there's going to be a lot of corneal edema, or maybe you're a learning phaco surgeon and you're still working on reducing corneal edema and it could obscure your view a little bit. That's really the only counter argument for not doing the phaco first, but it is certainly easier, and obviously you're not going to cause damage to the anterior capsule, or much less likely to if you've already done the cataract and you have the lens implant in place. All right, so I'm going to go ahead and share my screen here, and I've prepared just a quick, just a kind of a 10-minute talk here about toric lenses. So we're going to transition from the MIGS procedure. We will be able to answer some questions at the end of the morning on that. I wanted to just give you guys some pearls about toric lenses. Now, this is not a deep dive into toric lenses. There are so much information with astigmatism management. Our goal is not to cover all of that today. Our goal is in the next 10 minutes to basically give you the fundamentals. If you've never done a toric lens before, or if you're early on in your toric lens experience, I want to give you some pearls on how to do this successfully. So we're going to talk about, and we're going to do this without having to acquire expensive technology like aberrometers and femtosecond lasers. So let's talk about identifying the proper patient, how to measure the astigmatism, how to create a surgical plan, how to mark a patient preoperatively, and then how to place the toric lens intraoperatively, which we'll do with the live surgery. So my hope is here in the next few minutes, you're going to feel a lot more comfortable with this whole process. So patient selection. Obviously, you want to pick a patient who has some desire to reduce dependence on glasses or contacts. That's one of the main purposes for treating astigmatism. About a third of our cataract patients have at least 0.75 diopters of astigmatism or more. I would recommend starting easy. Start with a patient between 1 and 1.5 diopters of astigmatism. As you get into the higher levels of astigmatism, it requires more precision and more accuracy. So set yourself up for success. Start with easy cases with lower levels of astigmatism. You do want regular astigmatism on topography. You don't want to start with irregular astigmatism in cases of, say, keratoconus or ectasia or corneal scars. That's a whole different arena. So stick with regular astigmatism. And of course, you want to avoid cases that could have possible zonular weakness. So maybe pseudoexfoliation, post-traumatic cases, cases you're expecting complications. Good dilation is important because you're going to need to see those toric marks on the lens. So when you're starting out, do not pick small pupils or patients that have posterior synechii. And of course, you're going to need an intact capsular bag. That's always a requirement. Okay, briefly, let's talk about measuring astigmatism. There's lots of different ways to do it, right? There's lots of different devices out there. I'm not going to talk today about which of those devices are better. There's lots of opinions on that. When I started, I used a manual keratometer, SimKs from an autorefractor, and my biometer, simply because that's what I had. I didn't even have a topographer when I first started practicing. Hopefully you'll have access to a topographer that really can be helpful. I think the important point I want to emphasize is that I measure with three different devices. So what this little graph here, this is a real patient chart of mine. I measure each patient that's going to have a toric lens with a Varion, which is my digital marker, the lens star, which is my biometer, and then my topography. And then I can very quickly compare the three different corneal measurements. And I want to make sure that they agree with each other. I want to make sure that they're consistent. If you look all the way at the far right, I can see the magnitude of the astigmatism. And the magnitude of the astigmatism is roughly 2.5 diopters. I'm happy with that. And I can see that the axis is all at 180, 1, and 2. That all lines up. So I feel comfortable putting a toric lens in this patient. Now, just below that, you'll also see the stable refraction. And you can see that there's 3 diopters of astigmatism at 180. So a little bit more in the refraction. That could be because of lenticular astigmatism or posterior corneal astigmatism. Again, those are toric 2B lectures, so that we'll get to that on another day. All right, so now you've selected the right patient, you've measured their astigmatism. Now it's time to make your surgical plan. How do you do that? By the way, the websites and the resources, we're going to have that posted at the end of the talk here for you, so you don't have to feel obligated to write these down now. But if you go to the ASCRS website, they have a toric calculator page. It's open access to anyone. And that's what I recommend you start using. So you'll put in your basic information. You can see on the left there, your Ks, the axis of your Ks, your axial length, your ACD. You enter all that information in. It allows you to select which type of toric lens, whether it's an Alcon or a B&L or a J&J or a Star. You can pick which one you want to use, and then it will tell you where to put that lens and how strong of a lens to use, whether it's a T3, 4, 5, or 6. So all of the math is done for you. So it's a very simple process of just entering in key information and some key data into one of these toric calculators. Now, each of the manufacturers also has their own toric calculator, like Alcon. That's what I show here on the right, and you certainly can use those as well. Now, it is going to be important that you know what you can treat. So depending on which toric lens you migrate towards, I use Alcon lenses. I've used them for years. They have excellent rotational stability. So that's the one I'm most comfortable using. So I know that I can treat anywhere between 1 diopter all the way up to about 4, almost 4.5 diopters of astigmatism. So you want to be familiar with what the range is. I believe that Bausch + Lomb and Vista now goes up to a 5.75 diopters of correction, and that's inside of the US. Outside of the US, there's other lenses, toric lenses that are available that can go to even higher ranges. So you want to make yourself familiar with what you have at your disposal. All right, so we've selected a patient, we've measured our patient, we've now made our surgical plan. It's time for surgery. Well, before we can do the surgery, we have to do the preoperative marking. Why? That's because of cyclotorsion. Anytime a patient is laid back into the supine position, the eye has the tendency to cyclotort. So we now don't know where the true 3 or 9 o'clock position or the true 12 o'clock position is on that eye because it's rotated. So we need to mark the eye preoperatively. Now, some of us have digital markers, so we've gotten lazy. If you don't have a digital marker, and you certainly don't have to have one, then there's several ways you can do it. You can mark an eye at the slit lamp, you can do it freehand, or you can use a handheld toric marker. So I'll briefly show you each of those. These are images of a slit lamp beam being used to mark the axis. So the green reticle you see is the Toricam app. It's a free app that you can download onto your cell phone. And then you can hold that up to the ocular of your slit lamp and see where the slit beam is. Also, most slit lamps as shown on this video, actually have a toric marker. So this is a hog strike type slit lamp. And what I'm showing here is if you have a patient sitting upright, you can use the slit beam and you can put the slit beam on the intended axis of implantation that you got from your toric surgical plan calculator. And then once you have that slit beam centered on the pupil, you can now mark the eye. Now, if you have your slit lamp near your operating room, you can just use a marking pen and you can mark the ends of that slit lamp beam right at the limbus. If you don't have a slit lamp at your operating center, you could use a 27 gauge needle and make an anterior stromal puncture mark or scratch or mark the limbus. There's lots of literature out there on different ways of doing this. Now, if you don't have a slit lamp and you're not comfortable using that, you can just mark the eye freehand. So the important thing is, this is right before you bring the patient back to the operating room. You want to sit them up in an upright position. You want to have the patient's head in a neutral position, and you want to have them fixate. I usually have them fixate on my ear. I personally mark the 3 and the 9 o'clock position, or the 180 meridian. So you can see me doing that here. And this is fairly easy. You just hold the lids open, you have the patient fixate, and you have them sitting upright. Those are the important aspects of that. Now, this is doing the same thing, but now I'm going to use the Toricam app. And I highly recommend this because it's free and it's easy to use. So again, I have the patient sitting upright. They're fixating on my ear. I'm marking the horizontal meridian at 0 and 180. Now, did I get it right? Well, let's check. So I pull out my cell phone. I open up the Toricam app, and then I can use that app to make sure that the marks I made line up. And here I got it at 179. So I'm pretty happy with that. So I've now verified that my marks are accurate. You can also use a toric marker. The one here at the bottom is one of the more common ones. You put ink on these marks, and then you come at the patient and you place those marks, and it'll mark the 3, 9, and 6 o'clock position. I don't use these anymore because I did cause some corneal abrasions by trying to place this on their eye, and then the patient blinks and it could scratch or abrade the epithelium. Patients tend to have a little more anxiety when you come at them with a sharp device like this in the preoperative setting before they've been sedated. So I personally don't use it, but these are out there and they certainly can be used, especially with a little practice. Okay, so we have selected our patients. We have measured their astigmatism 3 different ways and made sure they're all, that they all agree with each other. We did our surgical planning online, so we know where we're going to put the lens and how strong of a toric lens we're going to use. We've now marked our patient, and so we have our reference point. So now it's time to actually put the lens in. So what I'm going to use today is a Mendez ring. I've already marked our patient. So we'll see the ink marks there. I'm going to use this Mendez ring, and I'll show you how to use that here in just a moment. On the right, this is from Cataract Coach from Dr. Devgan, where he's made some anterostromal marks in the cornea, and you could see those highlighted there in yellow on the axis of implantation. So that's just showing how you can use something alternative to a marking pen. So some of the pearls, you always want to aim for about a 5mm capsular rhexis because you want that capsule, that anterior capsule, to cover the optic of the lens. If you make a large capsular rhexis, it's increasing the possibility of that lens rotating or moving. It also can allow the lens to move more anterior, which can cause a myopic outcome. You usually want to leave the toric about 5 to 10 degrees, just shy or counterclockwise of the final intended axis. Then you'll remove the viscoelastic or the OVD from behind the IOL, and then you'll tweak the lens into its final axis. So that's not mandatory, but that's just a pearl of mine that's a technique that I use. It's easy to rotate the lens this way, much more difficult to go backwards. And so you want to avoid that if you can. And of course, you always want to keep in the forefront of your mind that you should abort a toric plan if complications arise. You never want to place a toric lens in the sulcus or in a compromised capsule. If that happens, do not put a toric lens in. Go to your plan B. Okay, Hunter, or I'm sorry, one last thing. If you have patients that come in post-operatively and they still have astigmatism, This is a great resource. Go to astigmatismfix.com. You can plug in all of the information, the preoperative data, and then the postoperative data, and it will tell you if the toric lens is where it should be. It will tell you if it needs to be rotated. And so it helps you manage a patient who has residual astigmatism or residual refractive error after a toric lens. Okay, so Hunter, over to you. I'll let you present the case while I go get scrubbed for this next case.
Yeah, thank you, Kevin. And I think Kevin said a lot of key things that I hope everyone heard. One is preoperative planning. You can see that Kevin measures thrice and cuts once. Also making sure the patient has a good ocular surface. With any of the advanced technology IOLs, the ocular surface is critical, and pre-treating any ocular surface disease is very important. Also, you can see, throwing yourself a softball, not having a patient with very complicated case, small pupils, pseudoexfoliation, or other zonulopathies are critical as you build your practice and your confidence with the toric intraocular lenses. These are very safe lenses. You can be off quite a bit and still bring benefit to the patient's astigmatism. So please know that while Kevin is precise, even if you're off 5 or 10 degrees, you're still benefiting your patients with these lenses and reducing their spectacle dependence. Kevin talked about patient selection and patient communication. I do think it's critical for patients to understand that these lenses, like any lenses, are trying to reduce their spectacle dependence. I would not guarantee or say, oh, you will never need glasses again, because even with perfect placement, patients may have some spectacle needs or perceive that they need spectacles, especially for up close vision or near vision, which is not what the presbyopic lenses treat. You can see that Kevin picked a really good case for us. It's a moderate myope, a -5, and that the patient has no other ocular pathologies. Both with the toric and the multifocal IOLs, you really want to avoid patients who have complex macular disease or other pre-existing conditions like Fuchs or other things that may compromise their outcomes, especially while you're early in your learning curve. One of the things I really appreciate is that this patient, is a 3+ NSC, so we'll watch Kevin kind of tackle a more dense lens, but don't let dense lenses prevent you from treating the patients with an AT-IOL or an advanced technology intraocular lens. These lenses really have revolutionized refractive outcomes now, where really patients are being perceived as cataract surgery being a refractive procedure, not just a sight restoring procedure. So, in the case coming up, you'll see that Kevin has already marked the patient, and this is different from his normal practice where he uses the digital markers and some of the advanced technology for visualization. But he's still doing the same pathway with regards to measurements, pre-op counseling, and patient discussions. And for me, that's critical. You can start your toric or your AT-IOL journey with minimal equipment. And as you build that practice, add new pieces of hardware or new equipment or new procedures to that. I would recommend with any of your cataract surgeries, but especially once you start new techniques or new technologies like toric lenses, to keep a surgical log and look at your pre-op and your post-op outcomes. Did the surgical induced astigmatism, SIA, that's something you're going to want to customize for your hands and your practice. So as you start your journey to becoming a refractive surgeon, I strongly recommend that you keep an outcomes log so that you can compare each patient, what was the pre-op and the post-op refraction, what was the expected refraction, and look to refine any of the variables that can help give your patients the best possible refractive outcome. As you can see from this slide, we are not going to throw ourselves complicated patients. Don't do the extreme myopes or the extreme hyperopes. Please don't have patients with traumatic cataracts or pseudoexfoliation where already there is going to be some challenges with zonulopathies or the stability of the capsular bag. You heard Kevin clearly say that every patient should have a plan B so that if you're not able to put a toric lens in the bag, you're able to have your monofocal ready and able to put in the sulcus or in another location. I see Kevin is starting, and I'll go hand it back over to Kevin as he puts the ring on the eye. Kevin, over to you.
All right, thanks, Hunter, great points. All right, so we are ready to start. So you can see the reference marks that I just showed you how to make. These are at the 180 axis or the 3 and 9 o'clock position. So this is a Mendez ring. This is a cheap, simple thing that any surgeon can obtain We're going to put the 180 and the 0 mark right on those dots. The intended axis for today's implantation is 120 degrees. So I'm going to mark the 120 degree axis on both ends, and that's going to be where I implant it. Now you can do this later, and I might come back and do this again because those ink marks could get washed away during the process of the phaco, but I wanted for demonstration purposes to go ahead and show you that. So normally what I would do is make those marks, say after I've put in the viscoelastic. So I've taken the cataract out and I've put in my viscoelastic and I'm about to implant the lens. That's another time that's perfectly reasonable to make your toric marks. All right, so pretty standard stuff here. You can see this is a very deep anterior chamber, much deeper before. So our first patient was a +3. This is a -5. Again, clear corneal incision, triplanar, using a 2.4 keratome. You can see the internal lip of the wound. Here's a straight line. That's a sign of a good wound that's going to seal. If it has that chevron incision, that's not going to seal quite as well. Start here in the center and start my capsular rhexis again, wanting to keep that capsular rhexis roughly 5 millimeters, so it covers the entire optic to help with the refractive outcome and the rotational stability. I would say when you're selecting a toric lens from the different manufacturers that are out there, one thing you really want to consider is the rotational stability of the lens. There have been some lenses out there when they first came on the market that were not as stable, and that's always frustrating. You do a great surgery, you put the lens where you should, and then it rotates post-operatively and potentially makes the astigmatism worse. You can see the golden ring here as I hydrodissect with a little hydrodelineation here. The lens now is really rotating. I like to open my incision with my second instrument as I bring my phaco needle in, just to prevent a decimase detachment that can happen right there at the internal lip of the incision. I'll make a couple of quick passes here to start a short central groove. Crack the nucleus in half.
Quadrant removal.
I'll then go into my quadrant removal setting and start back chopping the nucleus here again, striving to keep the phaco needle as centrally located as possible. This one does have a little bit more density to it. Keeping in mind, I do practice in Central Florida, not in Honduras or India, where you have light perception cataracts on a daily basis. Okay, so the nucleus is gone. I'm going to shift to my epinuclear stain. I'm not real aggressive trying to remove epinucleus with my phaco needle, meaning I'm not going to go out into the periphery to try to get all of the epinucleus with my phaco. You can take the epinucleus out with your INA. I don't want to put my capsule at risk, but if the epinucleus will come like it just did, I'll take it.
Cortex.
Again, I can't emphasize enough, if you have an anterior capsular tear, posterior capsular tear, you have zonular weakness or dialysis, you really don't want to put in a toric lens. The rotational stability of the lens will be compromised. You definitely do not want to put the lens in the sulcus. Have to remember our primary goal is to remove the cataract and restore sight. The secondary goal is the refractive outcome. And it's important that you don't confuse the order that our two goals should go in. Just removing the subincisional cortex here. Fortunately, my ink marks at axis 120 have stayed quite visible. There's lots of variability in the different sterile ink markers. Some are too thick and they'll bleed. So I would encourage you to get a fine point or a fine tip marker. Some of the ink markers, the ink will wash away very quickly. So you might have to try different types before you find the one you like the best. Okay, so our lens is now in the capsular bag. You can see the toric marks right here. 1, 2, 3 dots there, 1, 2, 3 dots there. So our goal is to line those dots up with axis 120. Now, there's still a lot of viscoelastic in the bag, and I've got to remove that. You do not want to leave residual viscoelastic or OVD behind the lens, because that can cause it to rotate. So what I'm going to do is I'm going to leave the toric lens here just a few degrees shy of its final implantation axis. Okay, I'm pretty close, but I'm about 10 degrees. I'm about 10 degrees away. I'll go ahead and put in my Trimoxy because it's easier to do that with my viscoelastic or my OVD in. All right, now I'm going to go. Now I'm going to stay in my Cortex mode, not on my viscoelastic mode. The reason is that the first thing I'm going to do is go underneath the lens and remove this viscoelastic. And so I want a lower vacuum and a little more controlled vacuum. So with my phaco machine settings, I prefer to have that on the Cortex removal setting, not the viscoelastic. All right, so now the viscoelastic's removed from beneath the eye, beneath the IOL. Now I can rotate the lens on axis.
You like to rotate using the phaco tip or the IA tip?
You can use the IA tip, or so in this case, because it's a myope, that lens rotates pretty easily. I can also use my second instrument.
Oh,
I think both perfect. Are acceptable. I don't know, Toric, do you have a preference?
No, I've seen it done both ways. I think what you just demonstrated was great, where you kind of do the majority of the push with the IA and then fine tune with the left instrument, the second instrument.
Yes, exactly. That's what I have found to work fairly well. Okay, so now we'll go ahead and hydrate our wounds. Get a good seal, get a good pressure in a formed anterior chamber. And then I'm going to go ahead and do my last adjustment here. And it's also important that the toric lens is centered. If it's off-centered, that does affect the toricity treatment. So you do want to make sure the toric lens is as close to the center of the visual axis as possible. Okay.
And I love how you have that such nice capsular coverage of the plate. You can see 360 degrees with that 5mm capsula rhexis. You're centered, you're clear, you have complete coverage and stability, and all the OVD is out. That's as good as it gets as far as surgery.
Thank you. So yeah, great point, Hunter. You really want that capsular rhexis edge covering the optic. I now can check let me focus down here so you can see the toric lens, the toric marks on the lens. Right here, they're right in line with my toric marks. So I'm pretty happy. I'm pretty happy with that. I think we can call it a day.
And so Kevin, that I don't know if you have any teaching points before we jump in the interactive Q&A. Were there any other points that you encountered in that case that you'd like to highlight, or do you want to jump into some of the questions from the audience?
Let's see, anything that you saw?
No, I think the keys that you did, obviously measuring thrice and cutting once, so you have confidence and clarity in your plan. And I think you did a great job with the OVD removal. So there's maximal contact with the plate and the bag so that we don't have that slippage or rotation that you talked about.
I was just thinking, you really touched on something earlier, and that was the just really paying attention to the preoperative measurements. Those are critical. You can do the perfect surgery, but if your measurements aren't right, you're not going to achieve the refractive outcome that you want. So also learning to pay attention to things like, the anterior surface of the cornea, patients with dry eye, or maybe anterior basement membrane disease, things like that are critical. And when you see the keratometric readings not aligning, if the axis is more than 15 degrees off from your different measurements, or the magnitude of the astigmatism is really off, then I think twice about putting a toric lens, because I don't want, obviously patients are having to pay more money for a toric lens, therefore their expectations are going higher. And if I see keratometric measurements that aren't consistent and that I can't really make a solid decision on, then I'll usually just call that patient back and say, hey, I don't think we should do a toric lens. I don't really have a definitive target that I can hit. And I think it's due to, whatever. So I think that that's a really important point, is sometimes we get really eager and wanting to use these toric lenses as we start to gain some confidence and some momentum. And we end up putting them in patients that maybe we shouldn't, because we don't have the measurements that we need. So I can't stress that enough, just how important that is.
Yeah, and you're fantastic with patient communication, also setting the expectations that, like during the first case, that they'll need to turn their head or look in different directions. So from the audience, Dr. Cahook himself actually was joining this morning and sent one of the articles about MIGS before or after phaco. So anyone who is watching, if you look in the chat, that PubMed reference is there. The next is a doctor who is asking, is your surgical position superior? And do you do phaco through a temporal main incision? Is that your routine position and technique? So tell us, Kevin, how do you like to sit for all your patients, and where do you put your main wound?
Excellent. Yeah, great question. And that's a fantastic question. So I sit at the 12 o'clock position. I sit at the head. And on a right eye, my incision is is temporal, so at axis 180. When I do a left eye, I'm coming in over the brow. So it's a little harder to get to that 180. So I'm really more at 160. And that's important, because when you do your astigmatism planner, the online planner, as you mentioned, Hunter, you have to include, or you should include, your SIA, your surgeon's induced astigmatism. So every time you make a primary incision, even if it's a small incision like a 2.2 or a 2.4 millimeter incision, you're going to affect the astigmatism. It causes a relaxing effect. And so on a right eye, for me, it's 180. On a left eye, it's 160. It's slightly different because I do sit at the head. So that's a really important factor to know about yourself. You can go to that same website that I referenced, the ACRS website, and they have a surgically induced astigmatism spreadsheet that you can download. I think you have to do maybe 50 of your own cases where you measure the Ks before and after the surgery. It's a pretty easy thing to do, and you can come up with your own SIA factor, and then you incorporate that into your surgical planner, because that can definitely have effect. It does shift, like just in this case we did, her astigmatism was at 115, but the axis of alignment surgically was 120. So why is there a 5-degree difference? Well, that's because of where I put my incision. And so that's an important thing. Now, 5 degrees isn't crucial if we're doing a T3 or a small level of astigmatism correction. But if you're doing a patient who has 5 diopters of astigmatism correction and you're using a T9 or a high-powered toric, that 5 degrees is going to be more critical. So it is important to look at that.
No, that's great. And I think just like you have to have comfort in your measurements, you have to have comfort ergonomically. Another doctor was asking, going back to your first case with the MIGS procedure with the Cahook dual blade, is the KDB disposable? Do you reuse that instrument in your practice and in your hands, Kevin?
Yeah, that it is disposable. It's a one-time use. You know, here it's FDA approved in the US for one-time use. I'm not educated on what that is outside of the US, but I would assume it's also for, you know, for one-time use. I will say out of all of the MIGS devices that are FDA approved here in the US, it is the most cost-effective one. It has a very reasonable price point, which I think is why it's great for global ophthalmology, no matter what economic system that you work in. You're going to have close to a third of your patients that will have mild, you know, glaucoma and could benefit from a MIGS procedure when they have cataracts. And so making it cost effective is a really crucial point. And some of these MIGS procedures, other ones are very, very expensive and very cost prohibitive. The Cahook dual blade, one, it works. Two, it's a fairly easy technical skill to learn. Really, the hardest thing is just learning the visualization. Once you learn the gonioscopy view and the visualization, doing the actual Cahook blade is quite easy. It's not technically challenging. But the kind of the icing on the cake is that it is quite affordable. It's one of the most affordable MIGS procedures out there.
And I'm going to come back to some of the questions about the torics. There's one more KDB question is, what is your preferred KDB goniotomy length? Both how many clock hours, what are you trying to treat? How much of the angle are you trying to treat in these patients?
You know, that's a great question. And I might not be as sophisticated as I should be on that. I think the knee-jerk answer is that I get as much as I safely can get. I'm never really worried about hypotony. I can't remember ever having a case of lowering the pressure, you know, too much. These are typically patients who have pressures above target, and they're, you know, in the 20s usually. So I will do as many as I can. So I'm trying to get 4 clock hours. Sometimes if I have a very cooperative patient and an excellent view, I can get a little bit more. So if I can, I will. Once I get up to the edge of my view on the gonio lens, I stop because I don't want to be cutting where I can't see. You can certainly do damage. You can disinsert, you know, an iris root or cause a cyclodialysis cleft or something there. So you don't want to work where you can't see. So I say the answer to that is do as many clock hours as you can with good visualization. And usually that's about 3 to 4 hours. Now, I will also say that there's newer gonio lenses out there that give a wider view. There's lots of single-use gonio lenses that are being made. So that's another area that each surgeon that you can explore is looking at the different gonio lenses, which might give you a broader or wider view.
And I think that gets into the next question about the, you know, how much is there a risk of KDB goniotomy, such as iridodialysis and Decimase? And I think the risk increases, as you've said, when there is a blind pass or not good visualization. In your hands, have you had many complications, or what has led up to any complications you've had with the device?
Yeah, that's a great question. I appreciate whoever asked that question. Anytime we're talking about a new surgical procedure, that has to be part of the discussion, right? Or what are the risks? I would say early on, I caused some hyphemas by hitting the peripheral iris. I don't think that I've caused, you know, irreparable damage, you know, where you've had to go in and fix, you know, an iris cleft or something like that. I don't think I've ever caused that, but I've certainly gone, the KDB has a tendency to want to go posteriorly as you advance it. So I did forget to mention that it does help to kind of angle the KDB up maybe 10 or 15 degrees to keep it in the Schlemm's canal or in the trabecular meshwork. Sometimes just because of the curvature of the eye, sometimes it'll start to dive posteriorly. And if you get into the ciliary body or into the iris root, it's going to bleed. And that's been probably the extent of the complication, is that you have a hyphema that you have to manage, you know, in a patient that already has glaucoma. And so that's just something to be aware of. And some of these patients do get hyphemas. Sometimes it's because you cause a little trauma to the peripheral iris or the ciliary body. Sometimes it's just retrograde flow from the collector channels that you just exposed. And so it is quite common to see a microhyphema first post-operative day, you know, so we manage that with a little steroid and we just watch their pressure closely for that. Other than that, yes, you could cause a Decimase by going too far up, but again, it all comes back to visualization. Where I see young surgeons get into trouble is when they get some bleeding, they just keep going. And it's kind of like, doing this and trying to drive down the street. It's just not a good idea. If you can't see what you're doing, stop. You can go in with viscoelastic and try to blow some of the blood away if you have blood obscuring your view. Sometimes you have an uncooperative patient, you just can't see the angle. So stop. Do no harm is still our guiding principle that we all learned in medical school. So if you can't get a good view, I would always say, stop or just do what you can with the view that you have, but don't try to go beyond that.
And I think that's a great point, Kevin. And certainly blood can obscure the view, but also tell you, that you are where you need to be. And you talked about the tactile feel. And that is why the KDB is a single-use device, is those cells that you're either blood cells or the trabecular meshwork cells can get in that pocket of that knife and never be able to be cleaned out. So it certainly is a single-use device, but also you want the sharpest instrument. So you have that tactile feel so that you know exactly where you are and how much pressure you should be applying. So, one question was, in very high myopes with the toric lenses, do we aim for the first minus spherical equivalent or aim higher to prevent myopic shifts post-op? So with very high myopes, how do you potentially calculate or alter the lens implantation? And B, what do you consider a high myope, a very high myope?
Okay, great, yep. So I could be wrong on this, but I think the definition is -8 or higher is what we're considering, higher myopes, the textbook definition. And I think that's true because that tends to be the dividing line from where we start to use, maybe different formulas, IOL formulas where the effective lens position starts to change and those kind of things. So really that question is not just appropriate for toric lenses, but for all lenses, right? And where it comes, so the point in this is that you have to be meticulous about where you put the lens, the toric lens, the axis, and how strong of a diopter or a strong of astigmatism correction that toric lens has. But you can't forget, you still have to do excellent emmetropic work, right? So if your patient comes out nearsighted or farsighted, but they have no astigmatism, well, you still haven't hit the mark. And so that really comes down to what lens formulas do you use with a high myope? So what I personally do is if they're at 25 millimeter axial length or higher, I also run the Holiday 2 with the Wayne Coke because that's been shown. You also can use the Barrett Universal 2. There's lots of different formulas out there, and that's a whole nother topic, right? So what I do is I run 3 different formulas when I have a high myope, and I usually get 3 different answers. But that helps me. And so sometimes I'll take the average of those 3 answers. So I might get one that says an 8 diopter, one that says an 8.5, and one that says a 9. So then you have to decide, okay, if you're going to have a little error, would you rather that patient be a -0.5, or would you rather them be a +0.5? Usually a myope would rather stay a little bit myopic as opposed to hyperopic. So I'll usually err on the side of just staying a little bit myopic. But I do encourage the use of multiple formulas when you get to high myopes.
No, I think that's a fair question. I always remember you want to take a long holiday. So holiday is the one I always use for the long eyes. There's another great question here. What is the cutoff point of post-op residual astigmatism or axis deviation, which require you to go back into the operating room and rotate it again? So in your hands, kind of what is the threshold, knowing that every patient's different, their expectations or their satisfactions are different. But what numbers make you think, hey, I just did the Birdall, calculator. I might take this patient back and spin the lens again and try to see if it gets back in position?
That's a great question. And I don't know that there's a correct, a one answer here for that. I think it depends on several factors. So one, is the patient refractively stable? Because obviously you can't make that decision at post-op day 1. Probably can't make that decision at post-op week 1. However, if their vision is, their cornea is clear, the anterior chamber is relatively quiet, and you expect the patient to be seeing well 1 week afterwards, but they're not, then of course you're doing your refraction. You dilate the patient and you document where the toric lens is, okay? That's the first thing I do is I'll dilate the patient. I'll say, okay, my surgical plan said I should have put this lens at axis 10. Let me dilate the patient. Okay, the lens is at axis 10. Great, it's right where I put it. So that shouldn't be the issue. Now I'll still run the Birdall, astigmatism fix just to be sure. Sometimes you put it at axis 10 and they come back and now they're at axis, they're 15 or 20 degrees off. All right, well, that's probably your problem. So I'll usually give them another week and check the refraction and check the lens again to double check. And if they're not happy, and I have evidence that says if I rotate this lens, I will make them happy, then that's what I'll do. And you want to do that relatively soon, within probably the first 2 months of surgery. And that's not a hard and fast rule. But as you know, the longer that lens is in there, the more fibrosis, capsular fibrosis will happen, which will make it more difficult to rotate that lens. So you want to do that sooner rather than later. So the window of rotating a toric lens, it starts when you have refractive stability, and it ends when there's so much capsular fibrosis that you can no longer rotate the lens. And that window of opportunity is going to be different for each patient. But that's the way I think about it. I've rotated some lenses that were 6 months out. There's a little nerve-wracking to do it, but sometimes it can be done. But you definitely want to do it earlier on if you can. I will tell you, it doesn't happen often. I rotate, maybe 1 or 2 toric lenses a year, and I do over 1,000 of them. So it's not something that happens very commonly if you're doing all of the preoperative measurements, everything that we talked about today. If you're doing that, that's going to keep you from making those mistakes.
There's 4 questions about the Trimoxy, so I think people were very interested in that. Is that what you do routinely? What is the volume? And how does that affect your patient's post-op drops? So 3 questions. Is Trimoxy your standard of care? What is the volume? And how does that affect their post-op drop schedule?
That is definitely my standard of care. I've done it exclusively for over 15,000 cases now, and I'm a firm believer that it is a really effective way. I've had 0 cases of endophthalmitis. The treatment for endophthalmitis is an intravitreal injection of antibiotic, which is what I'm doing at the time of surgery. The volume that I use is 0.2 milliliters, so it's a very small volume. I have a special cannula that's a shortened cannula that allows for that transzonular injection. You can also do a pars plana injection. However, I will say this: I do not recommend injecting any compound that's not being compounded by a certified pharmacy. There's so many risks to that. There's lots of risks of the surgeons doing it themselves, or the local pharmacy that really doesn't do compounding does it. And there's all different kinds of errors. They put preservatives in it. There's dilutional errors. And then you inject that into somebody's vitreous. There's lots of problems, right? So I only use the Trimoxy that's made by Imprimis because I trust their quality control. And this is what they do. So I can't speak for what is available outside of the US, but if you were going to consider it, I think it's great because my patients don't take drops postoperatively unless they need a non-steroidal. So my higher risk patients will take a non-steroidal drop if they're at high risk for CME or inflammation. But the vast majority of my cataract patients are not taking drops when I use the Trimoxy. It does affect their vision. They do get some cloudy floaters for a few days, but we warn them about that. We educate the patients that they're going to have that, but that's the small price they pay for not having to purchase and to use drops. I think for low to middle income countries, this is an excellent modality, especially when patients really have barriers to getting drops and taking drops. This is a fantastic solution to that problem.
No, I think that's fantastic. So I realize we've gone a little over time, Kevin. I just want to thank you again for being part of the Orbis family and doing another beautiful demonstration. We were able to come back from your prior live webinar and talk about the fundamentals of both MIGS and Toric IOLs, which I think will definitely only be increasing in usage around the world. I think MIGS are going to become more and more common throughout the world, and certainly the refractive cataract procedures are increasing globally. I know there's a few questions that we did not get to. We will answer those and follow up separately, Kevin, but I want to wish you a good day with the rest of your OR and thank you again. Do you have any parting comments? Christian Becker's on the phone, by the way, or on the line, so you may want to wish him hello in Peru, but are there any other comments or anything you'd like to say for our audience before we go?
Yeah, just thank you for this opportunity. This is the highlight of my week for sure. Great to share all of this with you. I hope it was helpful. Anyway, you guys are great. Thank you for the opportunity, Hunter. I really appreciate it, and all that you and Orbis do. You guys are really making a huge difference around the world. So great job.